Welcome, folks. Our apologies for a few technical hiccups here. We added some new security measures because the last time we had this seminar, we had a Zoom bomb. And so the new login procedure is a little more rigorous now. You have to be either logged in to your Penn State, not Penn State Health, your Penn State Zoom account, or you have to copy the link from the invitation into the browser that you use for your Penn State applications, and then it'll allow you to enter. And that was new to myself and Kristin, our presenter today. So we were learning things. But anyway, welcome. Thank you for your patience. My name is Terry Murphy, and welcome to I think this is the third episode of our CTSI BERD Biostats Epi Research Design seminar series for fall of this year. This program is hosted by Professor Lan Kong, who's the Division Chief of Biostats and Bioinformatics in the Department of Public Health Sciences. I'm Terry Murphy. I work with Dr. Kong. And today, this is our third successful session so far. We're very pleased to have Dr. Kristin Sznajder. Kristin, am I saying your last name okay?
Yes, thank you.
Okay. And she's going to give a talk called Best Practices in Perinatal Epidemiologic Research. And here are a few house rules. This Zoom session is being recorded, and it will be posted on a Penn State YouTube video. So we ask everyone that you have your microphones muted, and while the speaker is presenting, you can enter questions through the chat box, and I'll be monitoring those. But in general, we let the speaker present their entire seminar, and then we have questions and answers at the end. By virtue of having registered, you will receive the slides, a recording link, and a chance to provide us with some feedback after the seminar. And we'd be very grateful if you did take a minute or so to finish off that feedback, because it does help us. Once again, the name of the talk today is Best Practices in Perinatal Epidemiologic Research, Applied to Research on COVID-19 and Perinatal Health. We are delighted to have Dr. Sznajder here today. Dr. Sznajder has this wonderfully well-rounded education. She got a degree in psychology here at Penn State. Then she went on to Emory University for her MPH. Those of us in the Northeast like to think we have the best universities up here, but there's a set of very excellent universities in the South, which are kind of like the Southern Ivies. And Emory is one of those, as well as Duke and Vanderbilt. But if that weren't enough, then Dr. Sznajder went on to get her PhD in epidemiology at Michigan, which is, of course, one of the very staid and reputable institutions of this country. After she got her PhD in 2013, she spent a few years doing field epidemiology with the U.S. Army Public Health Command. And since 2018, we've been fortunate to have her here on the faculty in public health sciences. And she has done a lot of work since 2015 creating exchange programs that provide international opportunities for both MPH and DRPH students. And so I hand it over to Dr. Sznajder. Thank you, Dr. Sznajder, for honoring us with your experience and your knowledge in this subject. I will stop sharing.
Thank you, Dr. Murphy, for inviting me and for the introduction. I will attempt to share. So I think, looks like Is this the right view?
Yes, that looks good.
Wonderful. Well, thanks. Thank you so much again for having me today. Good afternoon, everyone. Thanks for being here for my presentation entitled Best Practices in Perinatal Epidemiologic Research Applied to Research on COVID-19 and Perinatal Health. Today we will review the methodological considerations that are especially important in perinatal epidemiology. And we'll discuss how study design needs to how we need to think about study design carefully in order to define the population at risk and the timing of exposure. Since pregnancy involves critical developmental windows, we need to think that through a lot when we're designing studies looking at perinatal health and perinatal outcomes. Okay, so today the objectives of this talk, we will focus on three main objectives. First, we'll review the field of perinatal epidemiology, and this includes understanding how we study pregnancy, birth, and newborn outcomes, and what makes this area unique compared to other branches of epidemiology. I'll touch on the special methodological challenges, such as timing and measurement, and the mother-infant connection that can shape how we interpret findings. Second, second, we'll look at three short research questions that we are working on right now in our project on perinatal health and COVID-19. So we'll talk a little bit about some preliminary findings and how we set up our population to study them. And then thirdly, we'll look at key takeaways. So perinatal epidemiology focuses on the health of mothers and infants during pregnancy, childbirth, and the postpartum period. This stage of life is vulnerable, and outcomes during this time can have lifelong consequences for both the child and the family. In this field, the outcomes we study may be maternal, such as preeclampsia, which is a morbidity during pregnancy, but it could be maternal mortality or other outcomes during pregnancy or postpartum for the person who is pregnant. They could be fetal, such as stillbirth, neonatal, like preterm birth or low birth weight, or they could be even infant outcomes, including growth and development. Some of the key challenges that we'll talk a little bit about today in the field of perinatal epidemiology are linked patients. So because mothers and infants are linked patients, our data needs to capture this connection. And furthermore, exposures can change over time, like infection and treatment and environmental risks. And this requires careful modeling and consideration in the short time frame of pregnancy. We also need to account for selection bias, and there's some special types of selection bias in perinatal epidemiology that we'll talk about today. And then also finally, heterogeneity across gestational stages. So that's, again, important when you're thinking about exposures during pregnancy. And here is just thinking of pregnancy. We often think of that in trimesters 1, 2, and 3. Okay, so when we think about best practices in perinatal epidemiology, there are several key considerations that shape how we design studies and interpret findings. First is the pregnancy interval. The timing between pregnancies has important consequences for both maternal and infant health. And when we study these outcomes, we need to make sure we're capturing intervals accurately. And this can be very challenging, especially in large data sets like claims or EHR data. I'll talk about that a little bit in this talk. Second, are time-varying exposure challenges in alignment with gestation. So again, understanding that duration of pregnancy and when exposure happens during that time frame is very important and pretty challenging to do. Clustering and hierarchical data. So this is generally thinking about all the clustering that can happen in perinatal epidemiology, which are things like when someone is pregnant with multiple. So if they have twins or triplets, those are all clustered together. When you have successive pregnancies, those could also be clusters. But you can also think of clusters in like in household level or health system level. So that's certainly be happening in data analyses with perinatal data. Another really important consideration in perinatal epidemiology is defining the population at risk. So it's very important to think about how you're defining that denominator. Should it be all pregnancies? Should it be all live births? And what do those different selections on your denominator entail in terms of how you have to interpret your data or what biases you may be vulnerable to? And then selection bias. So when you think about what's your population at risk, then you may have introduced or you may need to think about what selection biases could be impacting your study. Okay, so this is pregnancy interval, and pregnancy interval is, again, this is the time between the end of one pregnancy and the start of the next pregnancy. In clinical care, it's called birth spacing. So the WHO recommends waiting at least 24 months between between pregnancies after a live birth and for your next pregnancy. And then the US CDC and the American College of Obstetricians and Gynecologists suggest waiting at least 18 months. You can see in the US that we're hovering really around those suggested time points, with the median being about 2 years and a lot of people with these different intervals about between 1 and 2 years, it seems to be. But also you have to think about how we do this. And we really, oftentimes in EHR data and in claims data, we're defining pregnancy by ICD-10 code. So this can present a lot of challenges when you're defining this pregnancy interval. So it's critically important to consider this when you're setting up your data set. One of the biggest challenges in perinatal epidemiology is handling time-varying exposures and making sure that they're aligned with gestational age. So looking at this figure again, pregnancy is oftentimes defined by trimester. So these are with the first 3 months, the next, and the final over a 9-month course of pregnancy. But exposures could be happening at any point, and they could be either longer in duration or more acute. So trying to match up your pregnancy timeframe with your exposure timeframe is important and very challenging. Pregnancy is a dynamic process that also is very short in duration and can occur in multiple times. So it's a serious challenge. If you misclassify exposure, it could dilute associations, so you really want to be careful. And the best practice is precise gestational age data, but we don't have that a lot of times. Sometimes we can use early ultrasound data and can estimate pregnancy time up to that point. We may have last menstrual period. Those are usually available in birth certificate data. If you have ICD-10 codes, you can look for gestational age at delivery. There is an ICD-10 code for this, but it's not reliably used. So these are all kinds of interesting problems that come about when you're trying to figure out this time frame of when you're interested in defining your exposure and how you align it with gestation. Another major challenge is clustering and hierarchical data. A lot of times outcomes are not independent because they're correlated at multiple levels. For example, within a single pregnancy, twins or triplets share exposures. Across successive pregnancies, the same mother can contribute repeated observations. And in assisted reproductive technology cycles, ART cycles, this is for infertility treatment, multiple embryos can be linked for the same parents. Also, both maternal and paternal exposures can influence perinatal outcomes directly or indirectly. And so not only do you have that important detail, it's hard to disentangle the parents' influence on the fetus because they often share behaviors and environments if they're in the same household. This can even, perinatal epidemiology can even be considering intergenerational effects. So thinking about this hierarchical data can sometimes be overwhelming, but it's truly important to think about and to ensure that you're thinking of it when you design your study and your analysis. Because when you ignore clustering, it can bias your results and underestimate variance. So this is something that we worked a long time on in our data set, and it's quite important. So when you're defining your population at risk, you define that denominator, and that really defines your causal question. So one of the most critical steps of perinatal epidemiology is clearly defining the population at risk. This figure here emphasizes that selection can happen even before you measure exposures or outcomes. So for example, you have this conception cohort if you're interested in all pregnancies, but this is quite difficult to capture. If you're interested in viability cohort, ongoing pregnancies, which could be viability cohorts or term cohorts, then you need to think about how you're going to define that cohort of people, by which indicators in your data set, and what does that mean for your research question. And then if you decide to look only at live births, how does that bias your results? Why is that the right decision, and how does that impact your research question? So defining your denominator is really important. And there are two critical types of selection bias in perinatal epidemiology. The first one is selection bias on live births. Oftentimes, we use that population of live births, and that's for a variety of reasons. But when you do that, you're missing information on pregnancy loss as it relates to your exposure of interest. Well, that's known. There's a classic example of that called the birth weight paradox, and we'll talk about that in a couple slides. But that's something to really consider when you're defining your cohort. Secondly, left truncation. This is missing information on outcomes before the measurement start date. So when you're selecting on live births, it's important to really realize what that does. If you consider all conceptions, 30% are implantation failures, and another 30% are early pregnancy loss. These are just preclinical. Then when you get to the clinical stage where you recognize a pregnancy and you can recognize a loss, then 10% are clinical miscarriages, and then really just about 1% are stillbirth. And the difference there is stillbirths happen after 20 weeks gestation, and 30% will end in a live birth. So you're missing a huge number of people from your denominator, and this could really lead to bias depending on the research question that you're interested in looking at. So this is the smoking birth weight paradox, or the birth weight paradox. It's a classic example of selection bias in perinatal epidemiology. And the question is, among low birth weight babies, are the babies of smokers more or less likely to survive than babies of non-smokers? And when we analyze these data, what's interesting and surprising is that we see that low birth weight babies born to smokers can appear to have better survival than those born to non-smokers. And so there's been a lot of work to understand this, and it's quite interesting because, sorry, this keeps happening. I was just going to point here that when you have smoking is associated with low birth weight, but you have these other factors here that can be impacting both birth weight and infant mortality. So these could be things like other comorbidities, it could be socioeconomic status. But when you are selecting on low birth weight here, and you're trying to see if it impacts infant mortality, you're opening up this kind of, in this DAG, you're directing a cyclic graph, you're opening up a backdoor path to go here to infant mortality, and it can disrupt, or it can change your association, and it can change the true association by doing so. So that's why we can see in the data, we can see that among smokers, among people with low birth weight who had mothers that smoked, they're less likely to experience infant mortality than those who didn't. It's truly just kind of a trick that can occur in data sets when you're selecting on a collider variable. So we need to be careful not to select on these kind of collider variables, and to really understand our research question and what could be affecting causation within our study. Another type of selection bias is left truncation. Left truncation occurs when studies only include pregnancies that survive beyond a certain point. So maybe greater than the first trimester, which is usually when people come in for more clinical care. This matters really when your outcome is pregnancy loss, or if the outcome includes all conceptions. So, for example, in many data sets, they only capture pregnancies once they reach the second trimester, and this could mean that early outcomes are just not observed. So this is just called left truncation bias. If you're interested in looking at pregnancy loss, something you really need to be aware of, and you need to define your population of interest very carefully and consider the biases that could be introducing if you don't have that information from time of conception. And finally, an important bias in perinatal epidemiology, which is a type of misclassification bias, is called immortal time bias. I'm just going to explain this with this figure. I felt like this was the clearest way I could think of to explain it. But so in this figure, you can see that the x-axis has gestational age in weeks, and the shaded region before the red here is the time before exposure can be defined. So in this situation, this is when gestational diabetes is usually tested and diagnosed around 24 weeks. So if we don't have information on that exposure at any time before that. So any pregnancies that maybe were lost or ended in stillbirth before the time we could get the diagnosis and we could define exposure are these X's here. So these are counted as unexposed because we don't have information on exposure at that time. So that's that kind of bias where we really just don't know. We don't have information on exposure, but we have information on outcomes before we have information on exposure. And so that's known as immortal time bias. And generally, so again, just another kind of important bias when we're thinking of pregnancy research. So just to recap on the three main biases or three important biases in perinatal epidemiological research is live birth selection bias from restricting analyses to live births. So when exposures affect both survival and live birth and later outcomes, that's something to consider, and that's a pretty common bias in perinatal epidemiological research. Left truncation bias. This is bias from excluding pregnancies that ended before the study period started. And then immortal time bias, which is bias from misclassifying a period where the outcome cannot occur as exposed. So now that we reviewed some of the key methodological challenges of perinatal epidemiology, I want to talk about a case study on COVID-19 and perinatal health. The reason I think this is a unique situation, and this is because there was widespread exposure of COVID-19. It affected diverse populations and healthcare settings. There was variable timing relative to pregnancies, so you could get COVID-19 before conception, anytime during pregnancy or postpartum. And there is incomplete and inconsistent capture in the EHR. Testing availability changed over time. People's behaviors changed over time. Their mild or asymptomatic cases were probably undocumented oftentimes. You could be tested, I mean, it's not here, but you could be tested in places that were not in your health system. So that's another consideration, that we wouldn't have those diagnosis data if you were tested outside your health system. And then diagnosis dates may lag infection dates. So considering all of these things, pretty complicated and interesting to consider COVID-19, especially during pregnancy, which is a short time. So this illustrates exposure misclassification, can be selection on live births, and confounding my comorbidities in healthcare access. So this is going to be illustrated by a study that funded by the Pennsylvania Department of Health that was launched in 2021, entitled Pennsylvania Maternal and Infant Health in a Pandemic, or PA-MEPA, or just MEPA. This is a collaboration between Penn State Health, McGee Women's Research Institute at University of Pittsburgh Medical Center, Geisinger, Temple University, and within the PATH. So we also all of these health systems are part of the PATH network. And the PATH network was critical in this study because it helped us have a standardized way of extracting data and analyzing data across health systems. Pennsylvania is a valuable setting for this research as it's large and diverse, and it has both rural and urban populations, and it was affected by multiple waves of the pandemic. In this study, we looked at how COVID exposure and the pandemic-related disruptions were associated with maternal complications and birth outcomes, and it gave us a chance to apply these epidemiological principles we just talked about. So we can get a little bit into that in the next few slides. This really summarizes the study. This sort of summarizes the study. So this is the background. We were interested in COVID-19's impact on maternal and infant health and concerns about infection risk during pregnancy. It was driven by concerns about infection risk. The population was pregnant individuals during the pandemic, but really from June 2019 to we stopped getting EHR data in February 2025 and survey data just last month in September 2025. And we're interested in, we had a lot of research questions we were interested in exploring through this data, but some of the main ones were, how does COVID-19 affect pregnancy outcomes like preterm birth and low birth weight? We will talk about that today. And what are some of the maternal health risks like severe illness and ICU admission and mortality? And are there disparities by race or socioeconomic status, access to care, and rurality? Some of our key findings, but again, these are really preliminary still, are to strengthen perinatal care during pandemics, to address inequalities in maternal health, and to form guidelines for future public health emergencies. Next steps, we're pretty excited about looking at long-term child development outcomes. We not only have pregnancy data during that time frame, but we have 5 years follow-up. So we're hoping to be able to look at that for at least some of our cohort to see any kind of long-term childhood development outcomes related to COVID-19, and focus on maternal mental health. So there was a lot of research on maternal mental health challenges during the pandemic, and certainly our study captured that as well. And we also know that maternal mental health is a key consideration, and this is a major challenge in maternal morbidity and mortality. So those are some of the next steps we want to take. So we can talk a little bit more about the data sources in our study. Again, this was across 4 health systems in Pennsylvania. We used the PATH Common Data Model, which included data on diagnoses, encounters, procedures, medications, demographic data. Those are all standardized through the PATH Common Data Model, or CDM. So we were able to extract those data from the different healthcare systems and pull together. It was relatively seamlessly pulled together those data sources to start our data analyses. However, the PATH Common Data Model is extremely powerful, but it was missing a few maternal data points that were important for our research. And those were really a linking variable between mom and baby. So we have these data for the CDM on, we have the data from the CDM on moms and babies, and we needed to link them. So we needed to have this maternal module built to have a linking variable between the mother's ID and the child's ID. So we did that. And in addition, in this module, we have mode of delivery. We have birth weight, gestational age, admittance to the ICU for the pregnant person at delivery, and then admittance to the neonatal ICU. And then we have breastfeeding information during their stay after delivery. And then we've also taken the CDM data and matched it with area deprivation index by the census block group. So we were able to pull that variable and match it by census block in order to get neighborhood effects. And finally, we had a sub-selection of people from our larger EHR cohort across the state were recruited into the survey. And so we have survey data on a little bit more than 3,400 women. So this is our study population. We have the retrospective EHR cohort is what I was just talking about, paired mother-infant dyads, and the person needed to be pregnant anytime between July, I think it's actually June 2019 to February 2025, and she needed to be between the ages of 11 and 55. In our prospective survey cohorts, this was just a kind of a sub-cohort from our EHR cohort. She needed to be pregnant at the time of recruitment, and we followed her to 12 months postpartum. We started the survey in September 2023 and just ended last month. We only included one pregnancy per individual, and she needed to be at least 18 years of age, and we had the survey available in English and Spanish. Like I was mentioning earlier, it's really important to think about how you're defining pregnancy duration and intervals. So we had to go through this with our data as well. We defined pregnancy. First, we took pregnancy end. And so on the next 3 studies that we'll go over, all of them are live birth cohorts. And that's because that's how we could define our pregnancy duration. We had a known pregnancy end date of live birth. And then we would have in our maternal module, which we pulled addition to the CDM, we had information on gestational age in weeks. So we were able to, that's how we defined pregnancy duration. If we didn't have gestational age information on someone, we did use those ICD-10 codes at delivery if it was available. And if not, we used 281 days as a conservative approximation since childbirth. So that's how we were able to define the time the person was pregnant. But we have multiple pregnancies in our data set because it lasted over more than 5 years. So we had to define how are we going to find pregnancy intervals, and we did that by requiring 20 weeks between pregnancy end and pregnancy start. And all of this is done using ICD-10 codes and procedure codes in the common data model or in our EHR data. So in the end, this was our overall cohort, and how we had 114,174 maternal infant links, and the average age was about 30 years of age. We had 73% white, 14% Black, 4% Asian, and 3% other. 9% of our sample is Hispanic. The average gestational age is 38.6 weeks, and the average birth weight is about 7 pounds, 7 ounces. And then our survey cohort included 3,347 women, although this I think is older because we just finished this. We haven't even received our final survey data yet. So we're hoping this week or maybe next week we'll be able to pull and get that final number. And this is from the EHR too. I just thought it was interesting to see the COVID rate per month over time. And so you can see that this is January 2021 is by far the highest number of COVID diagnoses in our cohort. And this is really when vaccines rolled out, but it wasn't until a few months later that vaccines started being recommended during pregnancy. So what we're talking about are the 3 research focus areas right now in our project. We're working to understand what are the preconception risk factors for COVID-19 during pregnancy. Does COVID-19 during pregnancy, I'm sorry, this is a typo. Does COVID-19 pre-pregnancy affect prenatal hypertension risk? And then the third one is, does COVID-19 during pregnancy affect birth outcomes? So this hypothesis is pre-pregnancy obesity, diabetes, and hypertension are associated with higher risk of COVID-19 diagnoses during pregnancy. We really wanted to see, we know that pregnant women are at higher risk for severe disease, but what are pre-pregnancy risk factors that we could kind of help counsel those women in order to prevent any kind of serious COVID-19 or COVID-19 diagnosis or severe COVID-19 diagnoses in pregnancy. We know that these are established risk factors for severe COVID, and they're also common in pregnancy. And we know that people with COVID-19 during pregnancy have a higher risk of admission to the ICU and the need for ventilator, preterm birth, stillbirth, NICU admission, and mortality. So our methods are, so our exposures are clinical comorbidities up to 2 years before pregnancy. Covariates are sociodemographics. And then our outcomes are COVID-19 and severe COVID-19. And we just use logistic regression in this model. For this study population, it's very similar to the previous, but just to highlight, we had 17% of cases of COVID-19 during pregnancy, and about 9% had severe COVID-19 during pregnancy. So these are our adjusted results for COVID-19 during pregnancy, and we don't see diabetes or hypertension. They were both associated with COVID-19 during pregnancy in the bivariate analysis, but not the adjusted analysis. But obesity, yes, obesity is affected, remains in the adjusted analysis as an independent risk factor for COVID-19. So does cardiovascular disease, pulmonary disease, renal disease, and what I find quite interesting are depression and anxiety. So the interpretation, I think, is that certainly these could be suppressing these different comorbidities could suppress your immune system, and there could be some important biological mechanisms in place to make someone more vulnerable to infection or disease during pregnancy. Also, people with these diagnoses could be more within the health system and maybe are getting tested more often for COVID-19. So it's kind of hard to know which is which, but those are really how we're interpreting these results. What is a little bit interesting to think about is our substance use disorder reverse direction. In the unadjusted analysis, it was a risk factor as kind of more expected for COVID-19, but it became protective. So we're trying to figure that out, and I'm sure it's probably not a real artifact of a real association, but it could reflect differences in testing or something else, or some kind of bias that we talked about earlier in the presentation. So we'll be looking into that. And then prior COVID-19, I had expected that to be protective, but in fact, it was a risk factor for COVID-19 during pregnancy, and maybe this reflects just health behavior. So being at risk for an infectious disease, maybe you remain at risk because of your occupation or other things that could put you at higher risk. But that was actually our strongest risk factor in this analysis. So some of the two main limitations and biases that we've talked about, we did select on live births. So we didn't have any information on pregnancies ending in loss. And maybe those that ended in loss were more likely to have COVID, and maybe we were missing some important information. So it may underestimate associations. And then misclassification. So we did talk about COVID-19 it's based on ICD-10 codes. So we were missing probably quite a few number of COVID-19 cases, and maybe some miscoded comorbidities or undercoded comorbidities in the EMR. The second study that we're working on is COVID-19 is having COVID-19 before pregnancy or pre-pregnancy. Does that increase the risk for hypertensive disorders during pregnancy? Hypertensive disorders during pregnancy are a major concern and a big morbidity for maternal health. It can include chronic and gestational hypertension. It's when your blood pressure is greater than 140/90. and it's a big contributor to mortality, morbidity, but also mortality. COVID-19 and vascular health, emerging evidence of lasting vascular effects due to COVID-19, and there's a potential link between pregnancy-related hypertension. We decided in this analysis to look at early onset gestational hypertension and late onset. This is because they could have different etiologic backgrounds. So one could reflect placental dysfunction, the early onset gestational hypertension, and late onset is more commonly driven by maternal risk factors and not placental pathology. So in this cohort, we selected on live births. We have early and late onset hypertension. Exposure is COVID-19 diagnosis within 2 years before pregnancy. We have covariates like demographics, pre-existing comorbidities, socioeconomic factors, and health behaviors like smoking status. And again, this was logistic regression analysis. Our preliminary findings here is that a quarter of our population developed hypertension during pregnancy. 9% had early onset and 16% had late onset. In the unadjusted results, both were associated with COVID-19, but in the adjusted results, only late onset hypertension was associated with COVID-19. And this made sense to us because COVID-19 can lead to persistent vascular dysfunction, and it can lead to cardiometabolic events like hypertension and diabetes. And those don't really alter placental function. So this what we thought was kind of interesting and something that we're also finalizing at this time. So again, our selection bias, since COVID-19 and hypertension could increase pregnancy loss and be conditioned on live birth, we might have included COVID-19 hypertension cases that are milder. Misclassification bias due to our reliance on EHR data for both our exposure and outcome. And finally, our final hypothesis that I was bringing today is COVID-19 during pregnancy increases the risk for low birth weight and preterm newborns. Low birth weight and preterm. So baby born less than 2,500 grams is considered low birth weight, and a baby born at less than 37 weeks gestation is preterm. They are huge indicators of poor maternal health and important when we're considering perinatal health in general, and it's a major outcome in a lot of perinatal studies. So these indicators matter because it could really have long-term health impacts. Babies born late in low birth weight or preterm birth may be underdeveloped. They could have a higher risk of infection. They could be more likely to go to the NICU and have growth and developmental delays, and even later in life concerns and challenges. Risk factors for low birth weight are poor maternal nutrition and chronic maternal health conditions and pregnancy complications. Also substance use or at either end of the age, so very younger pregnant people or older, very more advanced age. If you have multiple pregnancies, if you have low socioeconomic status, Black race, and prematurity. And then global trends in low birth weight, you can see that here that it's very high in South Asia and Sub-Saharan Africa, and globally about 15% of all births are born at low birth weight. Zooming in on the US, our low birth weight prevalence is increasing, and this could be due to the COVID-19 pandemic. So it's one of the reasons why we are testing this hypothesis. In Pennsylvania, it looks like this. This is more really urban, and then some rural counties have lower birth weight. So COVID-19 can inflame the placenta and damage blood vessels. Again, these vascular effects of COVID-19. It can reduce oxygen and blood supply to the fetus, restricting growth and maybe ending in an earlier delivery. This can also be from fever or low oxygen related to COVID-19. Again, here we selected on live births, so we could define that pregnancy duration. Our outcomes are low birth weight and preterm birth. And here are our findings. So we had 10% low birth weight and 10% preterm birth in our cohort. We had 8% of people with COVID-19 within 2 years before pregnancy, and 17% of people with COVID-19 during pregnancy. We divided this by trimester because, actually, interestingly, initially we had only an association between COVID pre-pregnancy and low birth weight and preterm birth. When we divided it by trimester, we're actually able to see a more nuanced situation going on. In trimester 2 is if you had COVID-19 during pregnancy, during your second trimester, you're more likely to have low birth weight or preterm birth. If you had severe COVID-19 during pregnancy, you're more likely to have preterm birth in the first and second trimester, and then low birth weight in the all trimesters. And this probably may be due to just not contributing the whole third trimester to our study cohort. So we're definitely going to keep looking into that and figure out a way to assess for that missing time of people that had preterm birth in the third trimester. Finally, race is associated with preterm birth and low birth weight in most studies and also in our study. So is being in an urban environment and being a former or current smoker. This is vulnerable to really the same biases as the other two studies that we've already talked about. So these are the key takeaways. Make sure that you define pregnancy intervals and pregnancy duration precisely. This is really, it's actually really hard to do, but really important. So at least understanding how your data set lends itself to defining these and making sure you're looking at exposure during the time frame of interest. So that goes into the second point of model exposure timing explicitly. Align exposure windows. So is it preconception or by trimester or delivery with biologic plausibility, but and also figuring out how to do that within your data. Accounting for clustering and selection. So pregnancies are not independent events. It makes them super interesting to study because people can have many pregnancies throughout their life, and that's happening in different times in their life with different exposures. And so it makes it super interesting, but it makes it complex to study. And then again, selecting on live births can bias results. So we oftentimes do that, and we did that in all 3 of our studies. But it's something to remember and something to consider when defining that denominator. And interpret your data with causal clarity. So choose that denominator that you're really interested in studying and understand how that affects your research question. And then be explicit about what questionnaire analysis is truly answering. This is my acknowledgements. Our PA-MIPA study team of investigators, statisticians, our program manager and program coordinator. There are so many more people that we didn't have space to mention on this slide, but I'm really grateful for everyone on the study team and to all the participants and partners that helped make this huge study happen. And we're also grateful to our funder, the Pennsylvania State Department of Health, and then the Penn State Social Science Research Institute and the Penn State College of Medicine. These are references. If you're interested in collaboration or if you have any questions, feel free to reach out.
Wonderful. Thank you, Dr. Sznajder, for a great presentation. At this time, we invite anyone in the viewing public. If you wish, you can unmute yourself and ask a question of Dr. Sznajder. Bear in mind, it will be on a YouTube, so if you want to remain anonymous with your voice, you may not want to do that. I don't see any questions in the chat yet, but Dr. Sznajder, a couple of quick questions. Am I right in remembering that it was close to 25% prevalence of hypertension among the pregnant mothers in your sample?
That's right.
Boy, that seems huge. Was that surprising to you, or?
Not No, I mean, it's not that surprising. It's a major comorbidity that affects a lot of people during pregnancy. But it varies in severity.
Okay. The other observation I wanted to make is that you did a very nice job, I think, from the start, presenting all of the study design challenges. I think that question of defining the eligible population is one that gets too little attention in general. So I was really glad to see you make that your first point of entry. The other thing I noticed was you see the causal inference framework clearly, undergirding a lot of your research. Like, I wonder, how many in the audience actually know what a DAG is, a directed acyclic graph, or if they know actually what a collider does. Those are things I've taken courses on my own on the side, and they're super important tools. But they come directly from the causal literature, causal inference literature. So you can see why us having a course in causal inference is so critically important.
Yeah, I think it's really important, and it's very hard to not think about it in in this field of research, because there's so many aspects of perinatal health that we need to consider. And so yeah, it's very helpful to think of it that way, for me at least. Catherine?
Yeah, thanks so much for the really great talk,
Thanks.
Kristin. I was wondering, how did you deal with home testing for COVID-19, and how that's going to probably be less severe COVID-19 that gets tested for at home, and probably changes over the course of the study period? And yeah, lots of questions wrapped up in there.
That's a great question. It's definitely a tough one. Yeah, so yes, there's a lot of people testing for COVID at home, and those don't likely make it into the EHR. It may be more likely, we're hopeful that it's more likely that gets into the EHR, or more testing is done in the health system during pregnancy because of that time frame in someone's life. They're more, they access the healthcare system more often, and they can be sometimes more likely to report any illness that they had. That being said, we know it's not always happening, and we aren't going to capture that in our EHR data. But we do have a survey data. We didn't talk about those results yet, as actually we don't have all of the data yet. But we plan to do some validation there. So we did ask in our survey every time that they had COVID-19, the date that they had COVID-19, and any symptoms surrounding that. And so we hope to be able to see, okay, well, at least what was the difference in the self-report of COVID-19 diagnoses and our EHR data on COVID-19. But we will update you when we know. But that's how we're trying to handle that.
Awesome, thanks.
Thanks.
Okay, so anyway, thank you so much, Dr. Sznajder. We have 1 minute left, so if no one else is raising their hand or entering in the chat, we'll let you go. And I remind everybody, when you get the email in the next day or so, you can get a link to the YouTube presentation. If Dr. Sznajder agrees, we'll distribute her slides also, and then we really appreciate you filling out the very brief survey so we can continue to keep our finger on the pulse of presenting seminars in areas that are of interest. So thanks so much, Dr. Sznajder. Appreciate your time and sharing all your knowledge with us.
Thank you so much.